progress.
Good afternoon, good evening. Thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager from the IMST based in DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Director Margaret. Good morning, good afternoon, good evening, depending on wherever you are. It's an honor for me, once again, to do the press briefing on behalf of our Director General, Dr. Excellent Jean Kaseya, who is currently in DRC, but could not join the press briefing. And I thank you all once again for the continuous support and presence every week together with us to ensure that we send the right information, and also to all our colleagues who are definitely battling so many outbreaks, including Mpox, cholera, as we'll be discussing today. So since the 26th of August, we had the integration of cholera within the IMST with the launch of the cholera continental plan. So we'll keep on informing, as we've been doing, on how we move forward on the response to Mpox, but also to cholera. We'll just start with a good news. The CIFIA, the conference that is led by Africa CDC, the fourth edition will happen in Durban. So it will take place between the 23rd and the 25th in South Africa, and it will be an opportunity to gather between 5,000 to 10,000 African scientists, policymakers, stakeholders around the issue on health. Quite a number of discussion will go on the local manufacturing, on the outbreak management, on the CSU, quite a number of activities. It's in a very short time. We are taking advantage of the G20 that will happen also in South Africa, so that our voice can actually wait on the time where those leaders will meet. So it will really unite voice from across the continent and the global to reimagine the future of our continent. So the theme this year is moving towards self-reliance to achieve universal health coverage and health security in our continent. Next slide. So as mentioned a while ago, we were expecting to have what we call the ECG. The ECG is all our experts. We'll sit together, and for the sixth time, they review on how we progress on response to outbreak, how the outbreak is evolving, and whether we should still consider it as a public health emergency of continental security. So they decided to maintain, based on the assessment, a comprehensive update on the Mpox situation in the continent, including the epidemiological data, the challenge, the success, but also the environment, the global environment that we are all involved in. So while significant progress has been made, and then we can mention the lab decentralization, the testing coverage, the vaccination, quite a number of activity and action that we've been able to implement, they unanimously recommend to maintain the fixed. And this is based on the continued presence of surge in case. We've mentioned some new countries. Senegal today, we're highlighting how they respond to the outbreak. Gambia have some cases, Mozambique. So we have all those countries. We have Liberia, Ghana, Guinea, where the cases are still increasing. So based on that, they emphasize the need to address the persistent challenge in the surveillance, testing coverage, and vaccine access. So they further recommend to have a proactive, forward-looking strategy that include, of course, strengthening surveillance with the digitalization, which is implemented in many countries, but need to be strengthened so that we continue to accelerate the real-time response to this outbreak. But also because we've seen that the case fatality rate remain high, especially in some countries. We've seen Kenya, we were seeing also at some point Sierra Leone. They decide that it's critical to understand critically what is causing those deaths with those investigations. And of course, the issue of vaccine. We've been mentioning again and again that we need 6.4 million doses of vaccine for the continent, but we've not managed to get those 6.4 million. So far, we are around 5 million with the 1.5 million doses that will come to DRC. So we need more to ensure that the country has access to that vaccine, which we agree is not a silver bullet, but is critical, especially in some countries where the contact tracing remains a big challenge. So again, they want to maintain the strong continental coordination that has been implemented within the IMST. So we will meet again in the next 3 months, hoping that by then we will have sufficient evidence to be able to lift the effects. On the side of the ECG, we will recommend to the DG of Africa CDC, we have the IHR for WHO. The meeting is ongoing, and by the end of today, we also have the position whether they recommend a public health emergency of international concern. So we have the continental, which will be maintained, and then we have the feedback on whether the international concern will also be maintained or lifted. Next slide. Now, coming back to our issue, we still have the top four outbreak: Mpox, cholera, measles, and dengue. And then as we continue, we realize that the number of high risk and moderate keep on increasing in the trend that we expect to have much more than what we actually have in 2024. And this is the result of quite a number of drivers, which include the climate change, the crisis that we see in Sudan, which affected the spread and the accelerate actually as we're listening for cholera spread in Chad, in Sudan, and South Sudan. Next slide. Next slide. Now, looking at our epi situation in the continent, we continue to see a decrease in the number of suspected cases, as you see, around 1.7, bit of stabilization. The number of confirmed cases is pretty much stable, but we appreciate the almost 52% decline from the time we were at the peak as per now. So we are still encouraged by the decline that we are seeing. The other good news is that the testing coverage has increased, and this has been highlighted by the ECG as well. We moved from 30%, that was in the week 33, for the last 6 weeks, from 33 to 36. And then this week we were at 66%, which means that we are quite confident when we can say that 7% out of 10 who are suspected has been tested. And we know that the main challenge remain in some part of DRC where the testing coverage has also improved, as I will show later. Next slide. Next slide. In DRC, as I just mentioned, we continue to see the decrease on the suspected case, but also on the confirmed case, moving from 188 confirmed cases last week to 150, a 20% reduction. And it's important to highlight that we still have those three clades, the 1A, the 1B, and the 2B. So what is important to highlight in DRC is the shift. Previously, we were having Kinshasa, we were having the North Kivu and the South Kivu, that was the hotspot, but now it's really more moving to the central, the Sankuru, the Bawele, the Tanganyika, and still a number of zones de santé that are hotspot in the Sud Kivu. So currently 12 out of 26 provinces have been identified as hotspot, while at some point we were much higher than that. What is also good news is that this week we've not reported any death, and then you will realize that this is the first week for the last 6 months, I guess, when we have only one death at the continental level. One death is too much, but we appreciate all the effort that are being implemented in managing case to allow the continent to decrease the case fatality ratio, which at the continental level is around 0.5%. And as you see here in DRC, it's around 0.41%. Next slide. In Sierra Leone, also, the situation is stabilizing. You can see in terms of the number of suspected cases, we are around between 72 and 97, a small increase, certainly due to the intensification of the last week of the 0 case by the end of August, as we are already shift in September. We can see the test positivity rate also remains stable around 50%. So what is striking and important to highlight is the 85% reduction that we've seen from the peak to now. So now the transmission is low, but it is persistent. So which means that the hotspot containment and tight surveillance remain critical. That's the only way we will prevent to have some flare-ups when you have some cases coming again, though we were moving toward the end of the outbreak. Now, the most critical challenge that they are facing, and we are happy to see the reduction on the case fatality ratio, is the high fatality due to the people living with HIV, especially those who are not on treatment. So action has been taken to ensure that they provide adequate care to HIV positive patients, to make them priority in terms of vaccination, but also to ensure that within the community, the sensitization to avoid stigmatization is also implemented, to allow people living with HIV and any other to seek care and to be confident on the capacity the system has to take care of them at the hospital. Next slide. Going to Uganda, we have an increase of from 10 confirmed case to 31, which is an important increase. But when you look for the last 6 weeks, you can still appreciate that the reduction has gone quite low, though Kampala still accounts for 34% of the total confirmed case. So in the past 21 days, 22% of districts have reported new cases, while at some point we were much more higher. You can see at some point we were around 120 out of 146. Now being at 32, it's a very good sign that it's moving forward. Considering that also the Uganda will roll out the next round of vaccination, it's quite encouraging because they will target those remaining hotspots to ensure that even in those the proper population have access to the vaccine and therefore are protected against Mpox. Next slide. In Burundi, we are still seeing the decline over the time, but the transmission is still continuing, especially in Bujumbura North District, which remain the most affected, which represent 38% of the national total confirmed case. So now, out of the 46 districts that was previously affected, only 9 are currently reporting active Mpox case for the past 3 weeks. So those, once again, are the key area, the key district where all the effort are implemented to ensure that they reach the 0 case per week. That's when they will be confident on the stopping, controlling the outbreak in the continent, in the country, as we've been seeing in some other countries. Next slide. Now, moving to Liberia, where we were seeing the increase in the number of suspected cases, but also the number of cases. We can see that the number of confirmed cases is remaining stable with a slight decrease. But we see that from the week of week 21 onward, both confirmed and suspected cases surge. But then after that, we've seen that the reduction that we believe will continue, especially the country will push with all the surveillance activity, but also the vaccination. So the Montserrado account still the highest with 66% of the total confirmed case across all the counties. Now, out of the 114 active cases, 100% are currently being managed through home isolation, which is highlighting the contextualization of the response. If you move in a very neighboring country, which is Sierra Leone, all the cases are managed in hospital. In Liberia, they decide to manage the case at home, but we can still and happily see the number of deaths remain to 0. So it's showing that the country is able to manage properly the case and showing that they don't die. Next slide. In Ghana, we see this week a strong and significant decrease, especially in the number of suspected cases, 72%. In the number of confirmed cases, we are moving from 52 to 22 cases during the week. Still, the clade 2B is the one circulating. The test positivity rate is around 25%, which is quite reassuring on the capacity of the country to find the case within the community. Because when it's too high, it means that they find the case too late when they come to the hospital. So the week 29 to 34 marked the peak period with an average of 46 cases. Now, when we look at the other side, which is the contact, only 10 tested positive since the beginning, which is showing an attack rate of 0.4%. And this very small number tells us something. It tells us that though we manage to get the contact, so those who are being exposed because they're living in the same household with the patient, they might not be the true contact because of the sexual transmission of the disease. That's why you can see a very small number of the 2,800 almost, only 10 tested positive. Now, the other thing is that to stop the spread, it's critical with the communication to ensure that patients are more aware and open in communicating the true contacts. Therefore, they will be able to have access to the proper management. The Western, Greater Accra together account for 71% of confirmed cases, and that is a place where most of the critical activity are being implemented to ensure that the country also controls the outbreak. Next slide. Guinea, it's a country that we have been following very closely because we were seeing the exponential increase in the number of cases. So now we are gladly seeing the stabilization. You can see that we are around between 87 and 93% over the 2 weeks. Also in the number of suspected cases, we can see that it is stabilizing. But what is also more encouraging is the test positivity rate, which is around 45% and 40% last week. Though it's ideally, we want it to be around 30%, but also it's showing that the community-based surveillance is working. They are finding the case within the community. And we are working together with the country so that they also have access to the vaccine, ensuring that on top of the surveillance that they're implementing, the proper case management, you can see there is only one death out of the 731 confirmed cases, so that they can also have this extra tool that will allow them to control a bit more faster the outbreak of Mpox in their country. Next slide. Moving from West to Eastern Africa to Kenya, this week we can see the increase in the number of confirmed cases from 20 to 31, though the number of suspected cases have decreased. When it's like that, we appreciate the effort that are put in place in the country to really go into the community, look for the case. We saw the test positivity rate is around 40%, again, encouraging. And also knowing that soon the Kenya will launch their vaccination campaign, it's encouraging to know that they will go where the key patients are. We are thinking about Mombasa, where you see that 43% of the confirmed cases are, but also knowing that Nairobi is currently the third hotspot. It's critical to ensure that the vaccination happen in all the different districts where we are seeing some of the case. Only 4% of contact has tested positive, and this also highlights the challenges of actually being able to trace the sexual contact because of the issue of confidentiality and stigmatization. Next slide. Now, when we move to the issue of vaccine, happily we've reached the 3 million doses that has been delivered to 12 countries. Out of those 12 countries, 11 countries have been vaccinating. The last one remaining is Zambia, who is also planning their vaccination. 18 countries has granted approval for MVABN, and 2 countries consider the person on the 12, which is critical because we've seen that children, especially in countries that has been seeing the clade 1E and 2, have been affected. So it's critical to ensure that we also have the provision for vaccination of children, especially when we are moving toward a transition, when we want to equip countries that are endemic for Mpox. It's critical to have the regulatory setup to ensure that they are able to use the vaccine adequately. So more than 1 million of those has been administered so far, 985 MVABN and 39,000 of LC16. Above 920 persons have actually been vaccinated with at least 1 dose of the Mpox vaccine. So Mozambique has been approved a 6-round allocation of 10,000 doses that will help them as well to control the outbreak as an extra tool to the surveillance, the case management that they are currently implementing. So Malawi will receive the 33,000 doses most likely tomorrow, and will be then able also to launch to extend the vaccination activities in the country. Next slide. In DRC, where we are, an additional 1.5 million doses of LC16 is expected to arrive this week, and that will push us, the country, to 3 to 4 million doses that will have been received. So it has started already in Kinshasa, the vaccination. So now the next target is really the other hotspot, the Equateur, the Trapa, where they will be implementing the vaccine. So far, almost 39% has been vaccinated with a West rate of 30%, which is the main challenge that we face with this vaccine, because we need to have 250 persons at the same time, at the same place, to avail the vaccine. Next slide. As I mentioned in the introduction, cholera is now fully part of the IMST since the continental plan has been launched. The team with the different partners using the same model are working on what we call the Incident Action Plan, which will tell us exactly in the next 30 days what is going to happen in which country. You can see that this week we are 239,000 of cases, 5,274 deaths, which is already much higher than what we have in 2024 in terms of number of deaths. 23 member states are currently affected, which highlight, and that's the reason why our member state made that call of action. And now our role, our challenge actually, that it reached for an opportunity to use the model that we use for Mpox to implement the coordination, the response to cholera, which, as compared to Mpox, needs a stronger multi-sectoral approach, as I will highlight with the country that we'll be seeing now. Next slide. Starting from Chad, this morning during our meeting with the country, we had the Chad that has shown the situation. Chad today is the country that has the highest case fatality ratio, as you can see, 7%. They have 68 deaths out of 974 cases. And this is due to the very complex environment. So initially, the cases were all found in the refugee camp, but now they are getting out of it, going in the community. And the highest case fatality rate that we are seeing, half of it is actually happening in the community. So one of the key asks for the country was to ensure that they are supported in the surveillance, to ensure that we can actually go in the community, in the household, and provide all what is needed, the hydration, the IV fluid when needed, when patients are transferred to the hospital. But also the vaccine. They've already done a campaign with 1.2 million doses of vaccine, but they will definitely need more. They need more of those vaccines for those new districts that have not been vaccinated. So the country has shown this sharp rise in cholera case death and have increased in parallel. but they have intensified the case finding. It has been happening especially near to the camp, but now that they are moving out of the camp with the refugee coming from Sudan, but also with the people from Chad who are coming back out of the Sudan because of the crisis. Those are the ones that are the most exposed. And on top of that, you also have the flooding. They were highlighting how challenging it is to access some district during the rainy season, and that they have to bring on board the Ministry of Defense to ensure that they use helicopter to be able to transport medical countermeasure, and sometimes also water to ensure that the patient have access to water and medical countermeasure. So this is one example, as we'll see later again, that it's critical to have peace, because without this peace, we cannot properly manage and respond to cholera in Chad, in Sudan, and other countries. Next slide. In Congo, gladly, we are seeing a decrease in the number of cases. As you can see, we are moving from 26 to, in a small increase, slight increase from 19 to 26 cases. But when you compare to the peak, you can really see how the country has been working hardly to ensure that there is that strong decline that you are seeing. So in terms of hotspot, it's still the Congo, Ubangi, Musaka, Lukolela within Brazzaville, and the island of Mbamu and Talangai. The driver remained the same. The transmission concentrated along the Congo River. That's why what is happening in the DRC also affect the neighboring country of Congo, which we emphasize what is happening, the cross-border and the cross-border surveillance, and having the two countries working together on ensuring that they can limit the spread of those outbreaks. So what is happening now is really to support the country to fast-track the OCV microplan so that they can also have access to vaccine. A mission from the IMST will go to Congo next week to ensure that they have the proper element in terms of surveillance also, which will allow them to complete, to isolate, and to provide adequate medical countermeasure to the people who are affected. But of course, these are the action implemented to stop the outbreak. But critically, what is needed is the multi-sectorial approach so that access to water is not a privilege, but need to be for all the citizens. And that will be the key thing to avoid having the cholera spread. Next slide. In DRC, where we are also, we gladly see the decrease in the number of cases, but still we are talking about 1,549 cases, despite the 11% reduction. We are also happily seeing the reduction in the number of deaths from 67 to 50, which is a 25% reduction. So the hotspots remain the same: Kinshasa, North Kivu, South Kivu, Chopo, with a new spread to Kwango. In terms of vaccination, the coverage is around 45%. The campaign has managed to touch almost 3 million within Kinshasa, which means more doses will be needed to ensure that all those hotspots population have been having access to the vaccine. So in the last 6 weeks, 9 provinces still have a case fatality ratio beyond 5, while the recommended, the acceptable threshold is 1. So you can see the Equator is around 10.3%, the Sankuru 12%, 15% Kwango, Kwili 17%, and Trapa around 25%. Some of those is also because they have a low number, which means the percentage can raise quite faster. So the large vaccination campaign in Kinshasa will definitely lead to a reduction, but also highlighted the need for more doses of vaccine. And as mentioned earlier, when we were talking about the Congo, the continued cross-border coordination is critical, because the cholera is moving from one country to the other. And unless there is a holistic approach, a coordinated approach, we'll still have the spread of the disease moving from one country to the other one. Next slide. In Angola, we keep on monitoring how the country is pushing, trying to get out of these outbreaks. So we can see the stabilization of the case from 58 to 66. The number of deaths we have 2 days as compared to 1 day last week. The hotspot remained the same as Lunda Norte, with some emerging cluster in Yuge and the sporadic flare-up in Ula. From the discussion that we also have last week with the country, clearly they need also to have some support to have a bit more vaccine, despite those that they have received, that they have already used. But looking in the long term, the critical issue remains the same. The wash, so that the population has access to water. And this is why we need that leadership that is by the AU champion, the president of Zambia, that will push the country to implement the presidential national task force in those countries to ensure that all the ministry are all involved, as we've also seen this morning with Ivory Coast, highlighting how the different ministers or in charge are involved in the response. This is critical to respond, but even more critical in terms of planification, building latrine and all those ones. Next slide. In Ethiopia, also, we've seen a small increase of 10% in the number of cases, reduction in the number of deaths. We moved from 3 to 0, while the number of cases have increased from 159 to 170. So the OCV campaign has been happening both in the community, but also in the refugee camp. And as we can see, the driver remained the same, the refugee influx, but also the flooding, which affect the water quality. So when you look at this curve, you can really see this multi-wave pattern in reported cases, which means that the vaccine needs really to be implemented at all the new hotspots to ensure that the country control the outbreak, especially now with those hotspots in Amara. But clearly, and we keep on repeating the same thing, the long-term and sustainable access to safe water and sanitation is key. Therefore, re-emphasizing the need to have this multi-sectoral approach, which is now critical for the IMST to lead within the new continental plan. Next slide. In Sudan, Sudan is one of the most challenging countries, not only by the number of cases, which gladly are going down, also the case fatality rate is reducing, but we are still talking about 41 deaths. But why I'm saying is one of the most complex is because of the humanitarian crisis, which make very difficult the access to the country, the access for the humanitarian actors to provide the vaccination, to provide the surveillance, to provide all the medical countermeasures that are critically needed. So what we see and what is critically needed is really to scale the case management, to add the cholera treatment centers and the oral rehabilitation point in internally displaced person, but also in the community around those different camps. But again, the WASH remain critical. That's a long-term solution. While for now, by emphasizing the surveillance and the communication, we should be able to support better the country. But at the end of the day, we need to have sustainable solution, which go back to improving the access to water using a multi-sectorial approach led by the Presidential Task Force when it will be established. Next slide. In summary, Mpox continues to remain a continental public health emergency of continental security as recommended by the ECG and accepted by our Director General, His Excellency Dr. Jean Kaseya. The continuous decline in harbor countries is happening. However, Mpox remains quite active in some countries, Guinea, Ghana, Liberia, and localized cluster in Zambia. The 1 million vaccine has been administered, though we need more vaccine as we are still not achieving the 6.4 million of those that are needed, knowing that new countries will be piling to receive the vaccine. The surveillance, the vaccination, and cross-border coordination are key, are also part of the ECG recommendation. And on the cholera situation, we see concerning outbreak, especially in DRC and Chad, in Eastern DRC, but also even in Kinshasa, despite the reduction in the number of cases. The The continental plan has been launched and the incident action plan is being worked on so that we have some clear action with all the partners together pushing as we did push for Mpox. So this strong leadership is what we really need to drive cholera elimination by 2030, which include definitely the medical activity that we have, but more importantly and more critically, the activity on building latrine, ensuring people have access to clear water. So the next step is really the establishment of the Continental Task Force, which will be led by the AU champion for cholera, which will support the countries to implement their own task force, and also to ensure the multi-sectorial approach that I've mentioned. Now, next slide. As you are all aware, there are some suspicion. We are talking about suspicion of viral hemorrhagic fever in the DRC. Since the 28th of August, the Health Authority of Bulape Health Zone in the Kaseya has reported a cluster of suspected viral hemorrhagic fever. The index case was a woman was pregnant of around 34 years old, and since then the country is really deployed with all the different partners and actors. The team are in the ground trying to complete the result and the sequencing, and the Minister of Health will give us some information of the confirmation or not of those cases and what are the actions that will be implemented. So for now, we are on standby. We are supporting the country really to be ready in case it is VHF confirmed, but for now, this is what we have. Next slide. So what you see here with the data that are being communicated by the CUSP, which is the organ which lead the response, we have 53.8% of all cases that were male. More than 50% of the cases were between 20 to 39 years of age, and all cases presented with fever, with 48 presented with hemorrhagic symptom. So this is what we are having currently, and then we are all on standby to get the result of the different tests that has been done and the way forward on how we manage those suspicions. So with that, I thank you, and of course, be happy with all the colleagues online and physically here to answer the question that you may be having. Over to you, Director Margaret.
Thank you, Prof. Let's take the first two questions. We have Christopher, a journalist from Deutschland Radio in Germany. The question is, so far there have been 166 moderate and high-risk events on the African continent. If this trend continues, it's likely that last year's 219 events will be surpassed. What are the reasons behind this likely rise? That's the first question. And then the second question is from Toby of the Washington Post. The question is, how have UNAID cuts affected the response to Mpox? And how have UNAID cuts also affected the response to malaria in Ethiopia? Somali has seen a rise in diphtheria cases. Can that be blamed on the decreased funding from UNAID? Back to you, Prof.
Thank you so much for the two great questions. I will answer the second one on the impact of the cuts on the response, but also on malaria and in the continent. And then I will let Dr. Melcy, who is leading the Public Health Intelligence Report, which will be happy to answer the first question on the moderate and high risk. So we've been talking again and again on the impact of the USG and others actually reduction on the ODA, and highlighting the impact it has been having on the sample transportation, sample collection, and part of the low testing coverage that we've seen in some countries like DRC was because the key actor that were involved in the sample transportation was supported by USAID. We are talking about FH360 and others. So that has impacted significantly the response in that space. Now, there have been some coordination where other actors has come on board, but also countries has also invest to ensure that this can be limited. But at the broader level, one of the key comments from the ECG was that the case fatality rate that we are seeing, especially in countries like Kenya and Sierra Leone and even Uganda, was due to people living with HIV/AIDS. Those are the one that was representing 50 to 76% of the people dying of Mpox. And this is also, those people are also those who were not under treatment. So remembering that the cut has also affected PEPFAR, the ECG highlighted that this can be an indirect effect. The fact that the population living with HIV no longer have access to their treatment make them even more vulnerable to Mpox. This is also what this was also one of the key reasons why they highlight that we should continue the facts so that we can ensure that we have appropriate treatment for those patients so that they are less vulnerable of Mpox. Now, I will hand over to Dr. Mercy on the issue of moderate to high risk event.
Thank you so much, Prof. And good afternoon, colleagues. That was really a very important question. As you know, most of the outbreaks that we are currently reporting on the continent are happening in very complex situations. We're seeing a growing humanitarian crisis across different countries. And like we see in the cholera outbreaks that have been reported, of course, affecting even more countries this year than what we saw last year. We're also seeing how these humanitarian crises are causing mass displacement. And this is also leading to new introductions in countries that were previously not affected. For instance, we're seeing Chad, which initially was not reporting outbreaks for cholera, but is a host or is a recipient to many displaced persons, refugee people from from different countries within the Horn of Africa. And this has led to the introduction of an outbreak in Chad, just to name a few. Again, in the context of the current official decline of assistance across the globe, we are also seeing that this is heavily impacting on vaccination coverage, whereby non-governmental organizations that were really supporting community engagement activities to engage the communities for vaccinations are really out of funds due to this cut and are no longer in the position to do this job. We are also seeing that it's also impacting on vaccination coverage and then thereby also leading to highly vulnerable populations, especially for our children. And so they are more vulnerable to some of these vaccine preventable diseases. Again, in the context of natural disasters, climate change, we are seeing that being increased, as well as many more countries being impacted. Recently, we heard of the landslide in Sudan that has led to over 1,000 deaths. And again, some of these populations within those areas definitely are going to be displaced. So leading to, again, displacement and people moving with diseases. So all these are all factors that are also propagating the spread of the disease, but not also to leave out the positive side of it. On the continent over the years, surveillance has really been improved, not only by Africa CDC supporting member states, but also other partners. Governments are also beginning to invest more funds on epidemic intelligence and surveillance and genomic sequencing laboratory capacities. And this is also improving on the detection capacity across the continent, thereby leading to us being able to detect many more diseases than we were in the past. So the more you look, the more you see. Over.
Thank you, Dr. Mercy.
Thank you very much. Let's cross back to the floor. We have Kat Lay from The Guardian. Kat, you have the floor.
Thank you very much for doing this briefing. I wanted to ask a little more about the Mpox vaccines. You said that you need more. What are the barriers to getting those? Are they doses that have been promised that haven't arrived, or is something else going on? Could you also please tell me whether all countries with Mpox outbreaks have authorized the use of the vaccines? And you mentioned the 30% wastage rate in the DRC. If you could tell me a little bit more about why that's happening, that would be really helpful. Thank you.
Thank you, Kat. Back to you, Prof.
Thank you very much, Kat, for those very important questions. So to start with, not all the countries currently has a vaccine to authorize. And this is one of the work of the IMST to work together. It is a process. So the country will go to what they call the NITAG, go to the NITAG, who will advise the Ministry of Health on which vaccine to use, to which category of population in DRC we are able to use the vaccine for children under 12. In other countries, not the same. I think there are only 2 countries that has that approval. So you have all those regulations that are critical in helping country to have this AUA for the use of vaccine. And now what we are even asking them is to consider the use of fractionated dose, so that when you have 1 dose, it can actually be used for 5 people. So they bring the question back to the NITAG and then see how they can get those approval. No, for the question about the barrier and the access, the real barrier are the fund. And when we mean the fund at different level. The first level is at the fund to acquire the vaccine. So currently there are around 340,000 doses that has been secured by UNICEF, still at Bavarian Nordics, but because they don't have the fund to buy those vaccines, they are still on hold. So once that money will be available to buy the vaccine, then they can procure them and then ship to countries. Now, when they reach the countries, there is a need for what we call operational cost. What is needed for the vaccine to move from the warehouse to the actual patient, to the actual community. And that is quite substantial. That's why we see some countries that have been receiving the vaccine, but that are delaying on the use and the implementation because they don't have those funds. Gavi has estimated at $7 per dose needed to implement the vaccination. So which represents a significant amount, especially in countries that has larger population that are targeted by the vaccination. Now, the country like Mozambique will be receiving, I think, by tomorrow. So they have a new allocation so that they can have some of those available. There was a question on the west of 30%. The MVABN, the way it works is that you have 1 dose for 1 patient, 1 participant or 1 community members. What we are moving is toward the fractional dose, where you can actually use 1 dose for 5 people. But now, when you move to the LC16, which is the vaccine that has been donated to DRC using a bilateral agreement, they receive a first batch of 1.5 million. Now, they will also receive, by the end of this week, 1.5 million extra. That will make 3 million. So the challenge is that when you have 1 vial, you need to vaccinate 250 people before. If not, you have to put aside the vial. So which means that there is a critical need to have a great community engagement to ensure that the population that will need the vaccine are mobilized at present at the same place. This is the biggest challenge, knowing that also the vaccination has to take place within a short amount of time. So the country is really trying to ensure that they have the right formula, which also rely on the surveillance to identify the suspected case and the confirmed case short enough so that you can mobilize all of them and make the vaccine available.
Thank you, Prof. Let's take the next 2 questions. We have Jonathan Lambert, a journalist from NPR. The question is, do you have a sense of when the potential Ebola cases in DRC can be confirmed, and have aid cuts impacted the ability to quickly move samples to labs to get them tested? That's the first question. And then we have Lucia Blanco from the Spain International News Agency. The question is, are you worried if the cases detected in DRC turn out to be Ebola or another hemorrhagic fever, the response to a new outbreak will be jeopardized by the aid cuts? Back to you, Prof.
Yes, so I will start with the question on the sample transportation, which has come, and then we've mentioned that definitely the country has been affected. especially DRC, but then the different partners and the country themselves has actually tried their level best and ensure that they can compensate and limit the impact. On the side of Ebola, the press conference was ongoing by the Minister of Health. I was just checking to ensure that I have the right information. I think it will start in a few minutes, where the Minister of Health will tell us where we stand out of those suspicions. He is the one receiving the result, and then will tell us whether we are dealing with VHF, Ebola, or others. So we are waiting for that. Are we worried? No, we are not worried. We are not worried because we are prepared. We are prepared as the country. This is the 15th outbreak that has occurred in DRC. Also, the country is well equipped in terms of epidemiologists, in terms of all what is needed to respond. The challenge will come in terms of funding. And you rightly ask about the impact of the cuts. But what we want to highlight is that the countries themselves are the one leading the response. And we are glad that DSC a few weeks ago, when our Director General was around, has promised actually to use that innovative model of funding, using 1 or 2% of some of the taxes to invest in health, and especially in the epidemic fund. So this is one way they will manage to gather some funding so that before the external support arrives and it is needed, at least the country has the minimum that is critical to move forward. As we do speak now, there are teams who are in the field. They've not waited the international help to run the investigation. So it is still happening. The samples are being tested, trying to get the information, and then the deployment of the surveillance, the AP, and so on, to understand what is happening. Whether it's Ebola or something else, the fact that people are dying is of concern. So we are not worried, we are prepared. Africa CDC and the MST is working hand in hand with the government. Our Director General, Dr. Kaseya, is currently in DRC, discussing, as we do speak, with the minister, and see, based on the outcome, how they will be able to support.
Great. Let's take the next question. We have Monica Mayuni, a reporter from the Daily Nation in Zambia. The question is, what are the most trending public health threats in Africa currently, and why? And the second question is, following policy shifts by most countries with regards to support of the health sector, what measures has Africa CDC put in place for continued vigilance against AMR on the continent? Back to you, Prof.
Thank you. I will hand over those two questions to Dr. Cheng, because those are two critical questions which are critical on how Africa CDC is leading the surveillance, and also within that public health intelligence unit. Dr. Cheng.
Thank you. We are also joined here with the HOD, Dr. Mirawe. So we'll be very pleased if he can take some of those questions, especially around the AMR. But for the one around the most frequent reported public health threats, or those with the most geographical spread on the continent, we have cholera, we have measles, we have dengue, we have as well, we have cholera, measles, dengue, and we also do have other arboviruses that are also plaguing the continent, like chikungunya, affecting multiple countries as well. And the reason behind this, as I earlier mentioned, it's been driven by several factors. Cholera is actually being driven by the climate change that I initially mentioned, as well as humanitarian crisis, amidst very, very vulnerable or very weak wash infrastructures on the continent. For measles, as we know, we are also seeing low vaccination coverage with so many zero doses. And this is one of the reasons why we see many more children being affected, especially those under 5. And again, it's happening in the context of mass displacement when kids or children are being carried by their mothers during humanitarian crises across the borders or get to other areas. They definitely are missing their routine vaccination. For dengue and other arboviruses, we are seeing an increase in the vector spread, and due to so many factors. As humans, we are encroaching into the environment, whereby we are also having situations where we are, the humans are actually invading into the natural habitat or the natural environment, and really ensuring that we are spreading beyond the limits that have been designed for us to stay within. And so what is happening in this sense is we are seeing many more flooding due to all these encroachments, as well as climate change, which is also leading to floods, and as well as creating a more favorable environment for the vector. And so this is one of the reasons why we're seeing more arboviruses being transmitted by the vector Aedes. And again, we are also seeing that most of these diseases don't really have vaccines available for humans. For instance, chikungunya, the vaccine is still under clinical trial. So it's mainly supportive care or preventive measures that needs to be put in place. So those are some of the reasons why we're seeing an increase in the spread. But I'll leave Dr. Mirawe now to come in and add to what I've said. Over.
All right, thank you. Thank you very much. Good afternoon, good morning, colleagues. This is Marawi speaking, Head for Surveillance Disease Intelligence Division, Africa CDC. Just to step in on the question regarding this AMR, as Africa CDC, as you all know, last year in 2024 at the UN General Assembly, there was a political declaration on AMR, and Africa CDC also launched its landmark report in August, which was also advocated in the UNGA in September. And that was a critical document which generated knowledge in the gaps that we analyzed and the critical priorities on AMR. So after that declaration, yes, there is a geopolitical shift in priorities in different member states and engagement of all those partners who are committing in that forum. So what Africa CDC doing now? Currently, we are doing on both at strategic level as well as technical level. With strategic level, we are still moving to get advocacy and convening partners on taking this opportunity as well. In October, we are organizing an MR partners forum. All stakeholders will be invited to reinitiate again that commitment back to on track. We are not losing focus because of different dynamics here and there, but we are still we plan to reconvene partners, which is scheduled around the end of October, on 30 and 31st October, to really reconvene again and do renew our commitments on AMR. So in addition to that, currently at the strategic level, we have this continental forum to coordinate AMR initiatives across the board. That is still ongoing, and we will keep pushing on that agenda. At technical level, there are so many limitations in lab capacity across the continent. As you may be aware, we have a joint partners that we released another document on lab and AMR situation report across 14 member states across Africa, which only 1.3% of the labs have the capacity to do microbiologic tests for AMR. That is really a huge gap that we are currently bridging with all our efforts in Africa CDC, with the lab division, with expanding of laboratory capacities, including decentralization with AMR capabilities, diagnostic capabilities. And furthermore, we are also developing this training advocacy for stewardship, as well as a multi-country, multi-sectoral engagement on MCM, multi-sectoral coordination mechanism across different member states. These are some of the highlights that I want to just showcase. Then we are not really losing focus of AMR. AMR is a huge epidemic as well as pandemic that is really draining without making too much noise. Thank you very much. Back to you, Director.
Thank you so much, Dr. Miller.
Yes, thank you very much. We have 1 minute to the end of the briefing. I think I have one more question here on the cholera report that was recently launched. The question is, given the incorporation of cholera in what was the Mpox IMST in DRC, will a different incident manager now be appointed? And additionally, what will the working arrangement be between the two teams, the Mpox team and the cholera team? Back to you, Prof.
Yes, thank you so much for that very precise and operational question. So the request was clear to use the same IMST, the same umbrella to respond to the two different diseases so that we can improve the efficiency. But again, cholera is not Mpox. That's why we have added some new pillars, what we call pillars. Those are the different units that will dedicate some activity. And the pillar that is new is the WASH pillar, to ensure that the water and sanitation is really led specifically for cholera. Now, on the side of other pillars, surveillance, case management especially, there are some very specific activity and ways to operate which are different when you deal with Mpox and cholera. So for those one, we'll have, of course, extra support, extra expert, those who are being contributed on the plan. So different organizations are currently actually selecting all those experts that will come to support the IMST and to ensure that we can properly, efficiently respond to both outbreaks without losing the quality of response to one over the other. So based on that, we'll be able to have our new organigram, but at the continental level, at the level of the incident manager, at this point of time, they will remain the same.
Thank you, Prof. And with that, we have come to the end of the briefing this week. Back to you for your closing remarks.
Thank you. I hope the question was not whether they want to kick me out of the IMST.
Hopefully not.
Hopefully not. Thank you, Director Margaret. So thank you so much to our journalists, definitely, for being with us. And even with those questions, we can see that there is some follow-up, some monitoring, some accountability of all what we are doing, also ensuring that they communicate the right information. So Mpox continuing, we have the ECG that has decided that we need to go for at least 3 months to ensure that we bring it to the level where we are all comfortable in managing it. We have cholera that is still there, increasing, especially in places like Chad and some part of the DRC. We have this suspicion of VHF that we are closely monitoring, and I believe that in a few minutes we'll know exactly what is happened from the press briefing of the Minister of Health, which means that we are quite busy, quite engaged, quite enthusiastic.
Yes.
And as one question was asked, no, we are not worried. We are just prepared to handle all those different outbreaks in the most efficient way. Thank you.
Yeah.